Okay, so hi, I'm Elliot. I'm one of the junior doctors. I work at St James's. I'm doing MAU at the moment, which is why I've probably not seen many of you around. We just get the fourth years. So I was asked to come and talk to you today about vascular surgery. So what are we going to cover? We're going to talk a bit about acute limb ischemia. We're going to go on to talk about AAAs. We're going to go on to talk about chronic limb ischemia, a bit about venous disease, try and sum it all up at the end, and then we'll have a few questions. Just try and go with everything. Okay, so case scenario number one. So we've got John. He's a 58-year-old chap. He's a truck driver. He's got a 1-hour history of a painful right foot, which is becoming worse, and he's not able to move his foot as well as before. Looking at his past medical history, it includes type 2 diabetes, he's hypertensive, he's got ischemic heart disease, he's had 2 heart attacks in the past, and he's had a couple of coronary stents put in. He's got AF, COPD. He takes metformin, ramipril, simvastatin, digoxin, atenolol, serotype, and tiotropium, and his dad had a MI aged 50. Onto social history, he smokes 25 a day, drinks 10 pints at weekends, lives at home with his wife, and he's otherwise independent. So going on to examination, he's alert, he's afebrile, he's got a respiratory rate of 18, and his stats 91. You're probably not worried too much because he's got COPD. He's a little bit tachycardic, probably because he's in a bit of pain, and his blood pressure's okay. So looking at his foot, he shows you that. His right foot's very pale, it's cold, it's tender to touch. The sensation's not as good as compared to the left foot. It's got a reduced range of movement, and you can't feel his dorsalis pedis or posterior tibial pulses. So what do we think is going on here? Great, perfect. Yeah, so this is a case of acute limb ischemia. It's a surgical emergency, and the aim of the main goal is to revascularize the limb within 4 to 6 hours. So, any ideas what causes acute limb ischemia? Good. Thrombus is a good one. Yep, embolism. They're the 2 big ones. Yep, perfect. Yeah, unlikely the tourniquet, but those 4 are really good ones. So thrombosis and emboli, like you got the 2 big ones you need to worry about. These guys often have peripheral vascular disease anyway, so they might have previous bypass surgery, and they might clot off, and you might get an occlusion in there. Trauma, like you said, dissection, and this one, intraarterial injection for intravenous drug users. They might have injected themselves, and that probably will cause a thrombosis, and might have, the limb might become ischemic following that. So you probably all know the 6 Ps from the early years. Limbs are often pale, they're pulseless, they're perishingly cold, they're painful, there's often paresthesia and paralysis. And the mortality associated with acute limb ischemia is around 22%. So how do we go about investigating someone? So if this chap came into A&E and you guys are seeing him, what are the things you might want to do? Yep, Doppler's a good one. Check the flow. Anything else? Okay, yep, so we want to do some bloods. So we probably do a full blood count, unis, do a clotting if you're thinking about any intervention. If you think that there might be some blood loss, group and save is a good one. You might want to do glucose. And then this troponin came up. As I was preparing the lecture, I came across this, and I had a look in the literature, and there are quite a few studies that link a raised troponin with acute limb ischemia. It's not something I'd worry about for the exams. I kind of just included it for completeness. Like you said, a Doppler to check the flow is a good one. You might think about sending the patient for an angio to see where the lesion is or what exactly has gone on. An ECG and an echo, these are important to check for any rhythm abnormalities, any arrhythmias that might have caused some mural thrombus in the heart, and that's flown off and caused the ischemic event. And kind of going with preoperative investigations, you might think about doing a chest x-ray as well. Alright, so do you guys know about how you would manage someone with acute limb ischemia? What are the management steps? Feel free to shout anything. Yeah, good one. That's an option. Yeah. Yeah, good. Anything else? Stenting. Not so much stenting, but other endovascular procedures, which we'll come up to in a minute. Yeah. So the first thing, as an F1, just think about your ABCD approach. Think about resuscitating the patient. These guys will often be complaining of a lot of pain, so you think about some analgesia for them, and they often require opiates as well. So don't be alarmed if you're finding that IV morphine is what's needed. You think about some kind of anticoagulation, particularly if there's thrombosis, to prevent any further clot formation. So you often give them a bolus and then follow it by an infusion. There's really good charts in the trust that direct you as to what's needed. So going on to definitive management, and that basically depends on the degree of ischemia. So if there's irreversible ischemia, and these patients, when you examine this fixed mottling of the limb, the limb feels woody. You might see kind of petechial hemorrhages, and they often present, I think, probably quite late. And any kind of revascularization intervention here is probably not going to work, and they would benefit mostly from amputation, and the amputation rate in acute limb ischemia is about 16%. Complete limb ischemia, these guys will have the classic white, cold, pulseless, painful limb. And you already said some of the treatment options that you can do. So you might think about thrombolysis. You might think about angioplasty, so putting a balloon down there, and if there's some kind of stenotic lesion, and inflating it. You might think about putting a Fogarty catheter in and doing an embolectomy. And like you mentioned, arterial bypass is a good option for limb revascularization. And if there's incomplete ischemia, and these guys might have sort of delayed, absent or diminished pulses and delayed sort of capillary removal time, you might think about just giving them some heparin and getting some imaging, and they might not necessarily need anything doing to them acutely. And at the end, you want to identify and correct the underlying cause. So, for example, patients that might have a compound fracture and their ischemic event is caused by compression of the vessel or distortion of the vessel, you want to get that fracture sorted out. That's the main sort of reason behind the ischemia. So once you revascularize a limb, you're not out of the woods yet. There are some post-ischemic syndromes you need to be aware of, and that's relating to reperfusion injury. So once you restore blood flow to the limb, sort of the increased oxygen supply can sometimes lead to the generation of free radicals, and this causes neutrophil activation. And once the neutrophils are activated, they increase the permeability of the vessel wall, and can often lead to compartment syndrome, which we'll come on to. But this sort of increased permeability can have local effects, and that is increasing interstitial pressure and compartment syndrome, but it can also cause acidosis and hyperkalemia, which could lead to arrhythmias. The muscle damage could cause myoglobinemia, which can lead to acute tubular necrosis and acute kidney injury, and you can often maybe get gut edema, which can cause endotoxic shock. So these patients can become quite unwell afterwards. So compartment syndrome is a big one you've got to watch out for, and that's the increased permeability of the vessel leads to edema, and because the calf muscles are in kind of tight fascial compartments, that increasing pressure impairs blood flow and can cause muscle necrosis. And with these patients, their limbs will be really swollen, and they'll kind of scream out in pain as soon as you touch them. And you need to let someone know quite quickly, because they're probably going to go to theatre for a fasciotomy. Other things to be aware of are chronic pain syndromes. If the blood supply to the nerves themselves is damaged, that can obviously lead to chronic pain, and you need to think about things like managing medically with like gabapentin, amitriptyline, these neuropathic drugs, or you could think about sympathectomy, which is where you obliterate the sympathetic chain, and that restores blood supply and can help with pain and things like that. Okay. So moving on to case number 2. We've got James. He's a 70-year-old chap. He's a retired engineer, and he comes in with a sudden onset epigastric pain followed by collapse at home. He's also a diabetic, he's hypertensive, and he's got ischemic heart disease. It's often a theme with these vascular patients. He takes insulin, ramipril, atenolol, a statin. He's a smoker, drinks a little bit, lives with his wife and is independent. When you go to examine him, he's drowsy, he's afebrile, and there's not too many problems from a respiratory point of view. But the worrying thing is he's tachycardic, he's hypotensive, he looks really pale, and he's cool peripherally, and he's pretty shut down, and he's quite tender in his epigastrium, and you think that you might feel an expansile mass when you examine him. So what do you think is going on with this chap? Yeah, he's got a ruptured AAA. Okay, so quick little bit about aneurysms in general. They're defined as when you get a greater than 150% dilatation of the original diameter. And with aneurysms, it's important to make the distinction between true aneurysms and false aneurysms. So does anyone know what a true aneurysm is? Yeah, great, perfect, yeah. So a true aneurysm involves all 3 layers, and common sense says that a false aneurysm doesn't. So with those, you get collections of blood around the vessel wall that communicates with the lumen, and they're particularly relevant with intravenous drug users. They can often get pseudo-aneurysms or false aneurysms, and that's what's happened with them. Common sites are your aorta, your iliac vessels, femoral or popliteal arteries, and the complications of them, they can rupture, they can thrombose, and with that they can send off distal clots and cause embolic events. You can get fistulation, so with AAAs you might get aortogastric fistula, and that can often have pretty severe consequences with rapid deterioration and hemorrhage. You can get extrinsic compression of other structures in close proximity. So going on more specifically at abdominal aortic aneurysms, they're defined when the abdominal aorta becomes greater than 3 centimetres. Men are much more frequently affected than ladies, and the incidence is 5% in those over 65 years. Going on to risk factors, smoking, hypercholesteremia, being male, and there's a genetic link as well. And often these patients are asymptomatic in as much as 3/4 of them. They may present through distal embolization, so if you've got clot in the aneurysm sac, that could dislodge and cause an acute limb ischemia. What we worry about is when they rupture, and you can often get cause abdominal pain, they present with collapse and shock, and like we said, there's the expansile mass on palpation. Okay, so going on to investigations, they're quite different for those that have got a ruptured AAA as opposed to those that haven't. If you were seeing this chap in A&E, what kind of things are you thinking about doing? What do you want to get done? Say again? Yeah, fast scan's really good. So quick ultrasound, if there's any kind of diagnostic doubt. Say again? You could maybe think about doing a CT if the patient was quite stable and you were unsure of what's going on, but that could take some time. Yeah, definitely, really important. But in terms of investigations, yeah, what kind of bloods do you want to do? Yeah, so cross-match, these guys are probably going to need blood and a lot of it. So starting at 6 units, cross-matching 6 units is not a that's not too much at all. So you want to do your basic set of bloods, full blood count, unis, liver function tests. Think about an amylase. It's an important blood in any surgical patient. You want to do clotting if you're planning surgery, and like we said, cross-match. You want to do an ECG just to make sure that they're able to go under an operation, under anaesthetic, and think about doing an ultrasound. So investigations for a non-eruptive AAA are a little bit different. So there's got some of the same elements, but you obviously got a bit more time. So again, you want to think about doing bloods. You might want to do an ABPI just to check the peripheral circulation, and then the rest sort of are involved in planning surgery and making sure that the patient is sort of more likely to kind of come through it successfully. So we want to do a chest X-ray, an ECG, and an echo. Think about some pulmonary function testing, and then imaging, particularly CT, is important because you want to define the aneurysm anatomy, and that's important with managing them. Okay, so management itself for a ruptured AAA, you mentioned ABCD, and that's the real key. Prompt assessment and treatment, getting them to theatre, because untreated the mortality is up to 100%, and that's rapidly reduced if we instigate prompt and effective treatment. So have you guys heard about something called permissive hypotension? So it's kind of quite common to see patients' systolic blood pressure being kept around the 100 mark, and that's to sort of limit any further bleeding. So it's kind of a fine balance between making the hemorrhage worse and sort of reducing blood loss whilst keeping sort of organ perfusion up. You want to get in touch with the vascular surgery team as soon as possible. Think about some prophylactic antibiotics, possibly, but they need to go to theatre pretty quickly. Unruptured AAAs, we don't really offer surgery until the aneurysm gets to greater than 5.5 centimetres in diameter, and there have been lots of research that's shown that before this point the risk of surgery is greater than the risk of rupture, and 5.5 centimetres is the crucial point where when the aneurysm gets larger, the risk of rupture increases quite rapidly, and you need to start thinking about intervening. So have you guys heard of the AAA screening program? So it was brought out a couple of years ago, and it's offered to men aged 65 and over. They get a one-off ultrasound scan, and if it's positive for a AAA, they're entered into a surveillance program, and that's with regular ultrasounds and CT scans, and the vascular surgery teams keep a close eye on them and hope that they kind of monitor them until they get to this 5.5 centimetre kind of magic number, and then plan a procedure from then. And the treatment options are an open repair versus an EVAR. Have you guys heard of an EVAR? Yep, so EVAR stands for endovascular aneurysm repair. I've got a picture there. So this is kind of just a diagram to illustrate the two options. So the open repair is the traditional option, where you isolate the aneurysm sac, you open it, and you sew in a synthetic graft, which is often Dacron, and then you close the sac over the top. It's quite a big operation. We've seen in the laparotomy to open the abdomen and get down to the vessels. So that's associated with kind of a prolonged hospital stay and greater risk. With an EVAR, it's a minimally invasive technique. You gain access via the femoral vessels, and you can feed a series of introducers and guide wires, using imaging to see where you're at, and then you can deploy the stent graft to bridge the aneurysm sac that way, and it kind of reduces the additional risks of undergoing such a big operation like an open AAA repair. Okay. So again, all surgery is not without its risks, and the complications of AAA surgery is renal failure. You're often operating close to the renal arteries, And if you're having to clamp off vessels and things, you worry about ischemic events to the kidneys, also thromboembolic events. There's a risk of infarction, myocardial infarction, graft infection, and the big one that we worry about is death. Obviously, EVAR is a lot safer, but that's also not without its risks. And the main thing to do with that is endoleak, and that's where you get blood between the aneurysm sac and the graft. There are a number of different, I think 5 different types which you can read about to be aware of, but sort of the most common one is due to back bleeding from lumbar vessels, and that bleeds back into the sac, and that can often cause sac expansion and may lead to kind of delayed aneurysm rupture. And because you're doing things through wires and not sort of doing it by hand, visualizing the aneurysm properly, you can get failure of the stent graft, or it might move, so you often need to monitor these guys in years to come. Alright, any questions so far? I hope we're not going through it too quick. Everyone's okay? Okay, so case number 3. Jeff's a 58-year-old chap. He's a taxi driver, and he's been experiencing cramps in his calves for the past 6 months, and these have been getting worse over sort of 3 weeks. He could kind of walk 80 yards and do okay now. His exercise tolerance is 20 yards, and he's he says that he's waking during the night with sort of similar pains. He says his right toe has turned black. He's got multiple comorbidities. He's diabetic, hypertensive. He's got known peripheral vascular disease, and he's had an angioplasty before. And he's on a number of drugs to treat those comorbidities. Again, he's a smoker, and he drinks about 15 units a week, and he's independent. So on examination, he's alert, he's afebrile. When you go to look at his legs, he's got a pair of legs, they're quite shiny, and you can see that there's a loss of hair on there, and he's got a delayed capillary refill time at 4 seconds, and he hasn't got any foot pulses, and he shows you his black great toe. So what's happening with this guy? Yeah, perfect. So this guy's got chronic limb ischemia. So affects about 7% of men aged over 50 years, and again, men twice as commonly as females. And there are a number of risk factors and associations that you can see there. So in terms of the clinical features, the classic one is intermittent claudication, which this patient describes quite well. You can also get ulceration, gangrene, and rest pain, and I put them in bold because these are features of critical limb ischemia that you need to watch out for, and you need to expedite their treatment quite quickly. When you examine them, they've often got absent pulses, they've got cold limbs, their skin's quite thin, there may be some ulceration, and dependent colour change, and prolonged capillary refill time. And you can classify chronic limb ischemia according to the Fontaine classification system, 1 being patients that are asymptomatic, 2 where they have intermittent claudication, 3 where they have rest pain, and 4 where there's ulceration and gangrene. Okay, so what kind of investigations do we want to be doing for this chap? Yep, Doppler's a good one. Yep, angiography's a good one. Yep, very good. So anything like doing some bloods, your basic ones, again, clotting if you're planning surgery in a group and save. Might think about doing syphilis if you think this is an infective cause. If you want to do an ECG, again, planning for surgery and to rule out any arrhythmias. Think about doing an EBPI to assess the vessels, and the important thing is to get some imaging, because you want to see where the lesion is or the lesions, and it's important in planning surgery. So think about doing arteriography or a CT or MRA. Okay, so going on from investigations, how do we manage these guys? Good. Anything else? Yep. Exercise programs. Yep, those are good ones. So when you get to your exams, particularly your OSCEs, and you're asked maybe questions at the end, it's really good to think about management in terms of conservative measures, medical measures, and surgical measures, because often the examiner will ask you, there's not very much time, and you kind of might panic and get a bit of a mind block. So having kind of these kind of structures in place, and again with investigations, think about what bloods can I do, what kind of imaging can I get, are there any special tests or any additional tests that might help. Yeah, with management, think about conservative measures, medical measures, and surgical. So, like you said, exercise is really good. In chronic limb ischemia, a third will get better, a third will stay the same, and a third will get worse. I'm talking about weight loss and smoking cessation. In terms of medical management, antiplatelet agents such as aspirin might be used, and then you need to think about optimizing comorbidities, so diabetic control, hypertension, hypercholesterolemia, and then we've got surgical management. So what kind of surgical management do we know for chronic limb ischemia? Yep. So, say again? Yep, amputation is an option. Say again? Yep, good. So, there are a number of options. So you could do angioplasty, and that's good for short stenoses. You might think about doing a reconstructive procedure if there's sort of extensive disease, and you need to think about blood supply coming into the region, the blood supply going out, and what kind of conduit you want to use. And you can use either vein grafts or prosthetic grafts. It's not possible to do these kind of procedures in everyone, so you might think about doing a sympathectomy, and that can be chemical or surgical, where you obliterate the lumbar chain, sympathetic chain, and that improves blood supply to the limbs and can provide relief through that. And then, sort of end of the line, you start thinking about amputation. And these guys have often had previous failed procedures such as reconstructions or angioplasties, and the main aim is to relieve pain and reduce mortality. Yeah, so diabetics may already have an element of peripheral neuropathy, and if you were to go and obliterate the sort of sympathetic nerve supply, that can exacerbate it and make it worse. So you just need to be a bit careful. So going on to the last case, so not too long to go, we've got Jane. She's 48 and she's a female, and she works as a teacher, and she's got a 2-year history of tortuous swellings on her legs. They're quite painful and often worse at the end of the day, where they become swollen, and she says that they can often be quite itchy. She's got high cholesterol, and she's gravida 4, para 4, going back to your 4th year days. She takes a statin, and she previously used the oral contraceptive pill, and she says that her mum had problems with varicose veins in the past. She doesn't smoke, and she drinks a moderate amount, but she's otherwise independent. Okay, so going on to examiner. Her observations are pretty unremarkable, but when you inspect a limb, you can see that she's got these sort of dilated, tortuous vessels on the medial aspect of her right leg. Well, they're present bilaterally there, but particularly bad on the medial aspect of her right leg. So what do you think is going on with this lady? Yeah, she's got varicose veins. Okay. So the definition of varicose veins, they're tortuous, dilated segments of superficial veins associated with valvular incompetence, and they affect up to 1/5 of the population, and these are more common in the ladies. In terms of causes, often they're primary, and we're not quite sure what causes it, but it's believed to be, or in some cases, a congenital valve absence, but this is quite rare. Secondary causes are obstruction, so that's things like fibroids, ovarian tumours. things of that nature, destruction of the valves, arteriovenous malformations, and constipation's another cause. And in terms of risk factors for varicose veins, you all know about sort of prolonged standing, being obese, being pregnant, and having a positive family history and previously taking the pill. So in terms of symptoms, these patients will often say that their legs are unsightly. So it's a lot of kind of an emphasis on aesthetic reasons. They can be painful and they can complain of cramping and heaviness. They often itch and become swollen. And when you examine them, they might be edematous, they might be venous eczema, they can get ulceration, discoloration, they become inflamed, and you can get phlebitis. And then there's all those special tests that you probably know about, like Trendelenburg's and tourniquets, the tourniquet test and things like that. So in terms of assessing them, it's mainly a clinical assessment, but you might want to do a Doppler to look for valvular incompetence. But the gold standard is a coloured duplex ultrasound to get a visual representation of the incompetent valves. So NICE produced a document on managing varicose veins. The indications for the treatment are if they're symptomatic, so if they get recurrent phlebitis and things, if there's lower limb skin changes, if they've had or they do have a venous leg ulcer, that's an indication for treatment, and if they've got any superficial vein thromboses. And in terms of management, we want to treat the underlying cause if possible, and then go back to kind of basic principles of conservative, medical and surgical. So any conservative management measures that you know of? Yeah. Yeah. Good. Medical management? Yeah, you can do injections because of that. That's mainly it for that. And surgical? Any surgical options for managing varicose veins? Say that again? Yeah, that's an option. So I kind of, when I was preparing the lecture, tried to split it down for you. It's going to load. So conservative measures surrounding patient education, losing weight, taking regular walks, and avoid prolonged standing. Medical treatment options are your stockings. You might think about some kind of sclerotherapy, and that can be with laser or foam. And you might think about laser coagulation or radiofrequency ablation. And your surgical options are localized stab avulsions, that's sort of directed at particular varicosities. You can do this thing called subfascial endoscopic perforator ligation, and that's aimed at if you've got a problem with the perforators connecting the superficial veins to the deep veins. You can think about long saphenous vein stripping, and the sort of the classic one is saphenofemoral or saphenopopliteal disconnection. They're kind of the main ones. So varicose vein surgery is not without its complications, particularly bruising and hemorrhage and infection. The treatment might not be successful, so there's a recurrence rate of 20%, and the saphenous nerve runs in quite close proximity to the long saphenous vein, and that can obviously lead to saphenous vein nerve damage. Okay, so one last quick slide, just as a quick summary on superficial thrombophlebitis. That's where you get inflammation and thrombosis of your superficial veins, often caused because you've got a change in Verkop's triad, which you'll all know about. The risk factors, being obese again, having a clotting disorder, smoking, taking the oral contraceptive pill, pregnancy, those that are intravenous drug users, but obviously there's the iatrogenic cause if patients are having IV infusions or IV medications, and you can often get them following trauma. So these patients may complain of pain, their limb may be swollen, may be red, and you might be able to feel sort of a palpable knot, and that's the area of thrombosis. In terms of investigation, it's mainly a clinical diagnosis, and you manage these patients, again, conservatively, medically or surgically, with things like elastic supports, exercises. Think about obviously giving them some analgesia, and topical non-steroidals are good, like non-steroidal creams. You may think about heparinoid creams, and that's things like Hiridoid. And there's some evidence to say that Fundopyranox or low molecular weight heparins are possible options, but there's not that much evidence as yet. And if the thrombophlebitis is associated with varicose veins, then you might think about doing an operation and sort of removing the cause. So in conclusion, try to wrap it all up with a few kind of points. Acute limb ischemia and rupture AAAs are emergencies, and they require a quick assessment, appropriate investigation where it's sort of necessary, and then kind of proceeding to urgent management. Chronic limb ischemia is based upon you need a thorough workup to define the anatomy and plan your operation and your treatment. Varicose veins are common with multifactorial causes, and you need to remember the conservative medical and surgical treatment options. Good luck for your exams. Does anyone have any questions? Okay, I've got some questions if you want them. If you need to go, feel free to go. So question one, we've got a 65-year-old chap who comes to A&E with a 10-hour history of a painful right foot. On examination, the foot's cold, there's delayed capillary refill time of 6 seconds, and there's fixed mottling of the skin. So what would be the most appropriate definitive management? Yep, you're saying C, it's good. So you all kind of picked up on a bit earlier about irreversible ischemia with a fixed mottled limb, and you need to think about doing an amputation in these guys because there's a high risk that other treatment options might fail. That's question two. 60-year-old chap, he had an open AAA repair for quite a big infrarenal aneurysm 6 weeks ago. He's come to A&E. He's got a 4-hour history of generalized abdominal pain. But when you examine it, it's soft and there's no localized peritonism. Within the sort of subsequent hour that he's in the department, he becomes tachycardic and he drops his blood pressure as well. So what do you think's caused this? And hearing whispered C's. Yep, so this is mesenteric ischemia. So I want to try and get across one of the complications of AAA surgery is mesenteric ischemia. If there's some thrombus that's sort of dislodged and found its way into the supply to the bowel, they'll often present with the classic triad of sudden onset abdominal pain. They'll have no abdominal signs, and they'll rapidly proceed to hypovolemic shock. In terms of treatment, you need to think about possibly antibiotics. You might send them for interventional radiology, or might perform thrombolysis, but quite often they might need a laparotomy, and you might need to resect the necrotic bowel. So going on to 3, 58-year-old gentleman with known peripheral vascular disease. He's got a 6-month history of worsening leg cramps, which come on at a distance of 80 yards. When you examine him, he hasn't got any ulceration or gangrene, and he's got ABPI of 0.7. When you do angiography, he's got a 3 centimeter stenosis in the superficial femoral artery, and that demonstrates good vessel runoff. So what would the most appropriate definitive management be in this guy? D. Perfect. So angioplasty is a really good option because, like I said, he's got quite a short stenosis with good vessel runoff. So D would be a good option. 67-year-old lady with a known varicose veins is referred to her GP, by a GP, to SAU regarding a palpable lump in her groin. When you examine her, there's a 4 by 4 centimeter lump which is below and lateral to the pubic tubercle, and it's got a bluish tinge to it. It's non-tender, soft, and you can compress it, and it transmits a cough impulse. So what do you think it might be? Any takers? Say again? D? Yep, it's a saphenous varix. And these are dilations of the long saphenous vein at the junction between, at the saphenofemoral junction. The classic features that they are soft, they're compressible, they disappear on lying flat, and they may have a bluish tinge to them. In terms of treatment, you often do a saphenofemoral disconnection, and that's almost like, and that sorts it right out. So last question. A 68-year-old chap comes into A&E, collapsed at home. He's hypotensive, tachycardic, and he's cool peripherally. He's tender in his epigastrium, and he's got an expansile mass that you can feel. And what's the most appropriate initial action? I hear E. Good. So I kind of put this slide in to kind of just to emphasize kind of first principles of A, B, C, D, E. Seeing that he's got a blood pressure of 80/50 and he's tachycardic, you might think, crikey, get some IV access and start fluid resus. But it's important to go back to this, like I said, first principles, airway and breathing. And if you remember that for your exams, would be good. Any other questions? Everyone happy? Good.